My research here is on inequality and economic factors impacting on the burden, cirrhosis burden and the death rate of alcohol and alcoholic liver disease worldwide. This is part of a larger study that we have been doing on a global scale, where we have been analyzing different factors that impact on the weight of alcohol, both in cirrhosis and in death rates. And in this case, what we were analyzing, or what we are focusing in, is on inequality factors, or factors that are affecting the way people are drinking around the world, but that are related to the economy or to the equality within a country. The first thing we did was construct a large global database that was composed of the World Health Organization statistics, both for the outcomes, what we call the AAF, which is the alcohol attributable fraction of cirrhosis, and the age standardized death rate by cirrhosis. These come from the WHO, and we also obtained different parameters from the World Health Organization on drinking patterns and on different things. We looked at the United Nations program, Human Development Program, to look for economical statistics, the World Bank to look for economical statistics. We also looked at the UN for inequality statistics, poverty, development indexes, unemployment rates, satisfaction, quality of living. We analyzed a series of variables that reflected the way people were working, thinking, and the way they are living, and we saw how they related to these outcomes. Basically, what we saw was that more developed countries, because this is on a global scale, so instead of patients, what we're looking at are countries per se, and some of them are regions. So what we looked in a global scale is that more developed countries, or countries also with less inequality, are drinking more. Apparently they can drink more, they can afford more alcohol, but they can also afford to treat the cirrhotic disease by alcohol, because they have a lower death rate. So this is quite logical if you take into account, because countries with less equality, or that have less economical development or less development per se, might not be able to afford commercial alcohol so much. So the alcohol attributable fraction of cirrhosis is not so high, but people die more of this disease. We have seen different things, but what was really surprising, we were looking at economy per se, and when we started analyzing these indexes that reflect actually inequality within a country and the cost of inequality, which is basically not only that the whole country is developed, but the difference within a country between the rich and the poor. This is actually something that influences highly the way the cirrhosis burden is behaving within a country and in the world. So you might have a country that is highly ranked as a developed country, but then with an inequality index it will drop in that rank, because their people are not homogeneous economically, and this actually influences very much on the way they are drinking and also on the way they are dying. And this is important because it means that we're doing it on a global scale, but within a country, in order to establish policies for alcohol, they must also take into account these economical and inequality factors. We have been performing sub-analysis per regions, because we also see that regions vary differently, and one of the limitations of the study, which can actually reflect this, is, for example, Africa has almost no statistics in many senses. We are missing statistics for the outcomes, but also for the way the people are drinking, and the economical factors and the inequality factors that we're looking at. These are very poor countries. At the same time, we know that if they are drinking unmarketed alcohol, for example. So these kinds of analysis have to be applied per regions, which is something we are planning to do. And also within countries, once we have these results. No, a specific region, no, we have tried different things. For example, within America, Within North America, we have to divide USA and Canada versus Central and Latin America, for example, or versus South America. Within Europe, we have seen that we have to divide Eastern Europe versus Western Europe because of the climate, and there's also changes in the sense. So there are a lot of factors that we're trying to analyze to see how this is influencing. At the individual level, first what we have to do is actually change policies with alcohol. And the way this can impact within all countries, but taking into account specifically the way each country drinks, the way inequality and the way the economy varies within a country is what is going to define the way alcohol is, for example, publicized, or the type of alcohol that's drunk. These kinds of things might be important. For individual patient care, I'm not sure. This is more for an alcohol policy in the beginning. Afterwards, the idea is to diminish the quantity of people that are having alcoholic liver disease, that will die from an alcoholic cirrhosis. This will have to change first in the large scale. We are doing the sub-analysis per gens that I was mentioning. We are looking at other factors that we hadn't looked initially for this abstract, such as the cost of inequality. We will also be looking at other patterns, other global patterns that may affect alcohol consumption and alcohol death, such as climate, for example. We have been looking at this database, at this global database from different angles, and we will see what we can find that might actually help us define which countries are at higher risk for these diseases.